welcome everybody. My name's Simone Eaglin. I'm the business manager for Cumbria Safeguarding Adults Board. And thanks for joining us at the end of what I'm sure are very busy weeks. We've all made it. It's Friday afternoon, thank goodness. And today we'll hear from Suzy. I'll let Suzy introduce herself in a moment, but Suzy will share the learning from the Stephen SAR. And Stephen is actually his real name. We've used Stephen's real name at the request of his family for this SAR, which was published last month. So if I could just ask that you remain on mute during the session. If you can and you're able, pop any questions in the chat and we'll come to those at the end. You will notice that the session is being recorded. That is only intended for wider dissemination of the learning, so we could share that wider with colleagues who haven't been able to join us today. And during the session, I will be posting some links in the chat. However, I will also share those following the session. So it's just some useful links that relate to the learning from this SAR. So I'll hand over to you now, Suzy, if that's okay.
That's fine. Thank you very much, Simone, for the introduction. And I will start by sharing my screen. My name's Suzy Braye. I was the independent reviewer in this Safeguarding Adults review. And I was also the independent reviewer in a thematic self-neglect review that Cumbria Safeguarding Adults Board undertook the previous year. And my background is social work, but working in safeguarding and self-neglect, of course, if it's taught me anything, it's that this is truly a multi-agency endeavour, and it's good to see such a wide range of agencies represented here today. So thank you for having me here. It's always a privilege to engage with the human story that lies underneath a safeguarding adult review. It's a very sad story, of course. But the positive that can come from the sadness of that story is the learning that we can all take on board and take away and use to drive improvements in how we work. And self-neglect is a particularly challenging part of adult safeguarding, as I'm sure you are all aware. So there is a lot to learn from Stephen's situation. There's a lot to learn to add to what we already learned from the thematic review. So that's what we're here for today. So I will run through some slides, but I'm going to talk quite a lot onto the slides as well and give you quite a lot of detail. But I want first of all to introduce Stephen. Stephen was 62 when he died. He died as a result of severe infection in leg ulcers, which caused septic shock and multi-organ failure. So the causes of his death were natural causes, but the coroner at his inquest was very explicit in saying that self-neglect had significantly contributed to his death. And that is a fairly typical picture that we see self-neglect exacerbating physical ill health, and physical ill health then exacerbating self-neglect. So we have a kind of vicious circle, and Stephen's situation very much illustrated that. So he lived alone, and he was very attached to a pet cat, but of course that caused some problems within his home because of the poor hygiene and cat feces and animal feces infestation. He was in poor physical health anyway. He had osteoarthritis, he had hypertension, he had COPD, type 2 diabetes. He was a heavy smoker also, and he had been, since an early age, since his teenage years, he'd been quite a heavy user of alcohol over a long term, although it's important to note that he had been sober. There is no evidence that he wasn't sober for the 3 years before he died. So he had a number of health challenges, and he had very poor mobility as well. He also was hoarding, and so the conditions in his property were really very squalid. His bathroom and his bedroom were not usable He slept on a couch. He had no running water. So there was a lot here in the home that made it a very difficult place for somebody with this set of health conditions to live. He had involvement from a whole range of agencies as a result of awareness of his situation. So in the Safeguarding Adult Review, we heard from Cumberland Council, Adult Social Care and Housing, Cumbria Police, Department of Work and Pensions, the GP Surgery, Cumbria Fire and Rescue Service, North Cumbria Integrated Care NHS Foundation Trust, the North West Ambulance Service, and Riverside Housing, who were his landlord and had been his landlord for some time. So he wasn't short of attention, but the attention from all of those agencies was fairly episodic rather than a kind of consistent involvement. We learnt a lot about his family as well as a result of the involvement of his brother and sister-in-law, married couple, in the Safeguarding Adult Review. They told us that Stephen was the middle of 3 children. In fact, he had an older sister and a younger brother. They talked about him having been a very talented artist and musician in his youth, and he travelled. He played the guitar in a group. He'd travelled. He'd done tours in Europe, but he had experienced some traumatic losses during his youth, and he came to rely on alcohol. He was a heavy user of alcohol. He would drink to excess when he drank. Not all the time, but when he drank, he would drink to excess. And as a result, he became distanced from his family because they found that he almost changed character when he drank. The quote down at the bottom there is from his sister-in-law. Sober, he was a gentle soul, a placid, pleasant and respectful man, but intoxicated, he treated people very badly. And that did cause a rift within the family. He was also by nature quite a loner, and he was a very proud man. So they described him as a man of 2 halves, really. So that's a little bit of background. I'm going to come back a little bit more detail to Stephen's story in a few slides further on. I just want to turn attention now to the idea of a Safeguarding Adult Review. Stephen died in February 2024. The Safeguarding Adult Review was commissioned in 2025. And just to flag up just very quickly, I'm sure many of you are very familiar with the process of Safeguarding Adult Reviews. They arise under the Care Act, Section 44 of which requires the Safeguarding Adults Board and all Safeguarding Adults Boards across England to undertake a review in a situation where it comes to the board's notice that an adult has died or been seriously harmed through abuse and neglect. And of course, abuse and neglect includes self-neglect, and where there is concern about how agencies worked together to safeguard them. So the focus is very much on interagency practice and how agencies fulfill their own individual roles, but also how they coordinate their individual roles with each other and how that joint effort takes place to safeguard. And the purpose of a review, of course, is not to point the finger or allocate blame. It's to identify what can be learnt from what might have gone wrong, and indeed from what went right as well, and to apply that learning to the future of safeguarding in the particular area. So we're very much in the realm of improving how agencies work together to safeguard adults. And the background context to this particular, to Stephen's Safeguarding Adult Review was that the board had already undertaken the thematic self-neglect review the previous year. In fact, it was completing and it was coming to a conclusion at the time when the Stephen SAR was commissioned. The thematic review had looked into the circumstances of 6 individuals and was very much about extracting kind of common themes. It had a dual focus. It was asking the question, what can we learn from the stories of those 6 individuals? But particularly, are there common themes? Because it's the common themes across a whole range of cases that show up what we could call the systemic fault lines. So we're looking at the kind of the whole safeguarding system rather than just individual practice with individuals. So that was one focus, a kind of a looking back focus at the lives of those 6 individuals. The other focus was looking at the current situation. What are the strengths and challenges of self-neglect practice now, or at that particular point? So this was being carried out between 2024 and 2025. So we took evidence from practitioners, strategic leads about what was working well with safeguarding and what was not working so well. And that gave us an insight through the thematic review into what changes we need to make going forward. And we mentioned that because, of course, Stephen's review was, in a sense, built on the back of the thematic review. The Safeguarding Adults Board already had a whole set of recommendations from the thematic review that they were working on. There was an action plan that had already started. So with Stephen's review, we were not looking just to repeat the same learning. We were looking to see what Stephen's situation could add to what we already knew from the thematic review. So this was, in a sense, a more focused safeguarding adult review, and the main key terms of reference were about building on the learning from the thematic self-neglect SAR and to work out what additional learning Stephen's story provided. The systemic approach is important. If we look at what happens between an individual and the practitioners attempting to support them, yes, what happens in that interaction is pivotal and is crucial, but it's inherently influenced by further layers of the safeguarding system that are further back. It's influenced by organisational factors. It's influenced by interagency practice. It's influenced by strategic leadership from the board, and of course, all safeguarding takes place within a national economic context, a social context, where there are expectations about how people live and how we support people to live safely. So the systems learning is important, but with Stephen's situation, we were picking out 4 particular key lines of inquiry. We were looking at how risk had been managed, including safeguarding. We were looking at working together, how agencies had worked together. We were looking at organisational factors that might have influenced how agencies were working together. And we were looking at how Stephen's decision-making, how practitioners had worked with Stephen's own decision-making, because his decision-making was quite pivotal in how his story unfolded. So the methods that we used included seeking chronological information from agencies involved, and indeed giving agencies an opportunity to put in some evaluation and reflection on their own learning and their own reflection on their work. We were looking at operational perspectives as well. We held an event, a learning event with practitioners who had been involved with Stephen, and that gave us quite a significant insight into some of the challenges of working with him. And we also had 2 discussions with family members, face-to-face discussions with Stephen's brother and sister-in-law who had been involved with him. So those were our terms of reference. I just want to go back now to Stephen's story to talk a little bit more about the detail, because the detail is quite significant in terms of getting a handle on what his story adds to our learning. So I do want to delve a little bit deeper into his individual circumstances. We go back in gathering information. We went back to around about 2018, 2019, which was when when there were first concerns expressed about the conditions in his home, and these came to light as a result of his landlord's concern and Stephen's own particular concern about the state of his bathroom, the fact that he couldn't use his bathroom. So there were very practical challenges to him remaining hygienic in his personal care. The landlord raised concerns with adult social care, and adult social care did attempt to get in contact with Stephen. He was not very responsive to that. He didn't respond at that stage. So eventually, adult social care withdrew from that. So that was the first element, really, the first time at which there was an opportunity to intervene. He was re-referred by the landlord in 2019, and adding to the concerns there about the fact that he was depressed and about his use of alcohol. So at that point, adult social care did give him details about financial support to secure some cleaning of his property, and advised him about seeking support with his alcohol use. He was re-referred again in late 2019, and at that point an occupational therapy assessment did take place. The result of and looking into his need for better conditions in his bathroom so that he could improve his hygiene. The outcome of the OT assessment was that he would need a wet room with a walk-in shower, and the plans were drawn up for this. But unfortunately, when contractors were commissioned to undertake the work, they refused to do the work because of the conditions in the flat, and because particularly the conditions in the bathroom itself were so squalid that they were not prepared to work in that environment. Stephen, on the other hand, refused to clean the environment, or indeed to have it cleaned, or to accept any help to get it cleaned. So he declined at that point. So he also at that point declined referral to the health and wellbeing coach to assist him with his hoarding. So there were offers of support at that point that Stephen declined, and we entered a kind of stalemate position about the bathroom, that no contractor would work on it, and Stephen wouldn't undertake the cleaning that was necessary. I have talked with his family about this, and they feel that this was a matter of pride for him, that underneath the pride there was probably deep shame, and that this was what was preventing him from moving on the need to do that. So 2020, there was some police involvement. He was concerned, Stephen was concerned that a friend was taking advantage of him, and at that point the police did feed concerns about his vulnerability through to adult social care. In April 2022, we see the discussions about the bathroom surfacing again between the landlord and between adult social care, and there was a proposal to use adult social care contractors to undertake the work, but this proved not to be possible because the kind of work that needed to be done in Stephen's bathroom fell outside of the contractual arrangements that adult social care had for the purposes of minor aids and adaptations on the one hand and disabled facilities grant on the other hand. So because that work wasn't possible, and because Stephen was still entrenched in his refusal to clean the bathroom, there was no successful outcome to that attempt to remedy the situation. And it was at about that time, April 2022, that Stephen's sister-in-law became more involved with him. Although he had been estranged from his brother and sister and sister-in-law, he hadn't been estranged from his mother. His mother had remained in contact with him. But in 2022, their mother was admitted to a care home, and there was a risk. The sister-in-law felt that he would lose contact with her, and that would be damaging to her, to the mother, to lose contact with her son. So the sister-in-law then became involved at that point with Stephen, and spent some time with him trying to support him, sorted out some finances so that his financial situation improved, ensured that he had shopping. He refused to allow her to get him help with cleaning. But by this time, and the brother and sister-in-law are very clear that by this time he was sober. So he had moved away from his alcohol use. The next thing we see is June 2023, when the GP became concerned about the state of his property, and he was referred for a Care Act assessment, which resulted in a joint visit taking place between the occupational therapist and an officer from the housing association. That visit found the situation unchanged. The house or the flat was still too squalid for contractors to agree to enter to do the work, and Stephen was still declining to clean. And he was even at that point declining the offer of assistance, practical assistance from the landlord to secure the cleaning. So this was a stalemate, really, and the situation remained unchanged. And then their forward from that remained unchanged, was not revisited at any point. So the bathroom adaptations that had been planned way back 2019 still were never done, and the practical difficulties for Stephen securing his hygiene continued. We then start the kind of run up to his death in the middle of February. So in January, the GP became very concerned about the degree of his skin breakdown. He had very poor skin integrity by this time, and he was referred to district nursing at the end of January 2024. The district nurses visited and immediately made a safeguarding referral. They were extremely concerned about the living conditions in his home, and they made that urgent referral to adult social care. There was some debate about whether a Section 42 inquiry would take place. The adult social care triaged the safeguarding referral into a waiting list for Care Act assessment. District nurses entered advocacy to go down the Section 42 safeguarding route. So there was a debate at this time, but that didn't result in a Section 42 inquiry. It resulted instead in a Care Act assessment that took place very shortly before he died. So the final days, things escalated very, very, very quickly. He had been on the waiting list. Stephen had been on the waiting list for a Care Act assessment since the beginning of February, and that had not taken place by the time, on the 14th of February, which was a Wednesday, his health significantly deteriorated. And the district nurses who were visiting daily by this time were extremely concerned and felt that he was in desperate need of medical attention. So they called an ambulance. Stephen, however, declined to go along with the plan for him to be admitted to hospital. And in fact, he himself cancelled the ambulance. So again, a kind of stalemate about what needed to happen here. The district nurses were attempting to manage his skin integrity, but it was becoming increasingly difficult because Stephen himself couldn't bear the pressure on his legs from the dressing that were being applied. So he would often take those off as well. And the lack of hygiene in his home, infestation, were clearly placing him at severe risk. On Thursday, the 15th of February, the following day, the Care Act assessment took place. So the social care officer visited and undertook a Care Act assessment, from which emerged a plan with which Stephen agreed that he would be hospitalised. He would go to hospital. While he was in hospital, his property would be deep cleaned, and that on discharge from hospital he would accept a care and support package. At this particular point in time, adult social care were not able to put in a care and support package because of the conditions in the home. And indeed, district nurses were wearing protective equipment themselves in order to provide his skin care. So that was the plan. But Stephen declined to go to hospital that day. Even when the GP visited later that day, he declined hospital. He said he would go the following day. On the Friday, the social care worker who'd seen him the previous day did raise another safeguarding referral and specified that in the GP's and the district nurse's view, Stephen was at risk of death. That safeguarding referral was flagged for allocation the following week. And this is why I'm specifying that it was a Friday. Nothing would happen to that until the Monday, and despite the information that this was a very close to death, potentially close to death set of circumstances. The GP and the district nurse had planned to visit on the Friday, but Stephen declined to be visited before 6 o'clock in the evening. The GP rang him, spoke on the phone, and Stephen stipulated that he would only be available to be called upon after 6 o'clock. Stephen's sister-in-law and the district nurses maintained contact throughout the day, attempting to liaise with Stephen, and eventually went round to try to gain access to his property, but found the house in darkness, unable. They were unable to gain access. And at that point, the district nurses, having taken advice that afternoon from their safeguarding advice team within the trust, called for a police visit. Police and ambulance, police called and an ambulance was called, and Stephen was found collapsed. He needed very urgent medical attention there and then in his home, but he was then admitted to hospital in a critical condition. And once in hospital, he very quickly experienced 2 cardiac arrests, which resulted in his death. So some very, very sad circumstances and a very rapid escalation, which I think is significant and gives us quite an insight into something that is additional learning from what we saw in the thematic review previously, because none of the 6 people whose circumstances we looked at in that review had experienced such a rapid decline in that kind of self-neglectful situation. So I want to, the next 4 slides really capture some of the key learning in those 4 key lines of inquiry: risk, Stephen's decision-making, interagency practice, and organisational factors. And the slide is organised here on the left-hand side. We have some good practice, and it's so important to flag the good practice and to learn from things that go well. It's as useful as learning from things that don't go so well. So it's really important that Safeguarding Adult Reviews point out the good practice and that we recognise that and learn from it. So risk was recognised in Stephen's situation. All sorts of risks from his environment, risks from his lack of hygiene, risks to his health. Fire risks were recognised as well because of the hoarding, and some actions were taken. There were care and support needs assessment referrals. There were referrals to the health and wellbeing coach to support him. There was a referral and indeed a visit from the fire and rescue service. Safeguarding referrals were made, and there were some very proactive attempts to secure a safe outcome at points of crisis. So the district nursing team in particular, and indeed the GP in alerting to the dire state of his health, made attempts to secure a safe outcome at those points of crisis in the final week of his life. But although risk was recognised, and I'm moving over to the things that didn't work so well now, recognition of that risk didn't always lead to an appropriate risk management response. There was some reflection from agencies who had not raised safeguarding referrals that they could and maybe should have raised safeguarding referrals. In particular, the police reflected on this, the Fire and Rescue Service reflected on this, and indeed the GP as well. So although there was a referral from the district nurses and there was a referral from the social care practitioner who had seen Stephen and witnessed the conditions in his property, other agencies hadn't raised referrals, so there wasn't that kind of weight of referral that might have been helpful. Then sadly, responses on risks that were referred were not as timely as they needed to be, given the rapidity of his decline. So whilst one wouldn't be saying that a wait of almost 2 weeks for a care and support needs assessment was too long, it was too long in the context of Stephen's situation and what was known about Stephen's situation. There was a major failure to secure a satisfactory outcome on the bathroom adaptation. This wouldn't necessarily have been easy given the stalemate that existed, but the fact that continued for 5 years it really played into the decline of Stephen's home and of the hygiene and his ability to maintain hygienic conditions in the context of his health challenges. And I think we don't know this for sure, we can't also discount the effect on an individual's state of mind and mental health of living in such circumstances and not being able to do anything about it. Stephen was, one could say, unreasonably resistant to securing the cleaning, but his family have cast a light on that, saying that he was a very, very proud man and probably underneath it deeply ashamed, and that would have caused him a lot of distress. And then thirdly, the pathway that was chosen to manage the risk that was referred by the district nurses at the end of January, the decision that was taken to take that risk management through care management wasn't an effective pathway, because the plan that emerged from the care management involvement didn't take account of the urgency of the situation. So we see a real focus here in this learning on the way in which we work. How quickly can we work when we need to work quickly, and how do we know when we need to work that quickly? So some ongoing questions coming from this key line of inquiry: how do we manage reluctance of the kind that Stephen showed? It's like very, very reluctant to accept and do the thing that could well have moved things on for him and improved things quite immeasurably. There was a very short timescale of involvement here. Involvement was generally in kind of short bursts and episodes, rather than a kind of a longer term attempt to engage with him. So questions really: are we persistent enough? Do we make it possible for practitioners to be persistent enough? The third question is about the how well equipped we are to identify extreme, urgent and routine levels of risk. It's all risk, but there are certainly different grades of risk, and we saw that in Stephen's case very clearly. Are we equipped to identify? Do we know? Do we see the markers of there being differences between emergency risk management, extreme risk management, urgent risk management, and routine risk management? How do we respond to the different levels of need there? And are we accurate in our risk assessments? Do we worry enough? One finding from the thematic review was that we tend not to worry enough about self-neglect, about the rapidity of the decline, and about the how an individual can so rapidly be overtaken by fatal health challenges. Do we worry enough? Do we worry enough soon enough? I think is an important question. So the second aspect of learning, second key line of inquiry, was about Stephen's decision making. And here I think it's important to flag up that the underlying causes of his self-neglect and of his refusal of support were not well understood. It's, I mean, I should maybe flag up, it's not on the slide, but there was a lot of good practice in terms of how practitioners, in particular district nurses, spoke and talked with Stephen and explained their concerns, and the GP also explaining concerns, expressing concerns, giving him information on which to make his decisions. So there was good practice here, but the involvement was really quite short term in those last 2 weeks, and Stephen's views were very, very entrenched. But those generally could not be well understood because that relationship hadn't developed. And yet we know that one way forward with self-neglect, particularly where people are resisting change, is to build relationship and to gain trust. And that enables the individual then to move forward. But that didn't happen in Stephen's case. Another key element here that was not done as well as it could have been was consideration of his mental capacity. There was no assessment under the Mental Capacity Act of his mental capacity to make the decisions that he was making, both about the care of his environment and the care of his personal hygiene, and of his acceptance of medical care and indeed hospitalisation. It's not clear really whether his capacity was considered and not thought necessary to assess it, or whether it was just not considered. We have comments like practitioners felt that he had capacity. There was nothing to suggest he did not have capacity. No concerns were raised about capacity. The GP has reflected that was there maybe reliance on historical determinations, so assumptions that were no longer justified, particularly in the context of him being a long-term and excessive user of alcohol, which can, of course, cause damage to the frontal lobe of the brain and therefore can damage decision-making and the ability to carry out decisions that we can still talk about, but actually can't then implement. So the whole topic of executive brain function, which came up in the thematic review, surfaces here as well. And later, of course, as he declined physically, the changes in his physique will have affected his brain function and his capacity to make decisions. But in those circumstances, it would have been preferable and safer to ensure that a formal assessment of his capacity to make the decisions to decline treatment and to decline hospitalisation would take place. So that really was quite an omission, and that does raise some ongoing questions. Do we understand all the factors that can affect people's decision making? Do we understand the impact of alcohol, potentially alcohol use, on the brain? Do we understand the speed with which physical decline can affect brain function and decision making, and therefore mental capacity? And are we sufficiently clear on when it should be assessed under the Mental Capacity Act? Formally assessed, not just there being nothing to suggest that it shouldn't be assessed, just not a feeling, not just feeling that he has capacity, not just being able to have a conversation that sounds quite rational, but it's about taking that a step further and undertaking a formal assessment. Are we clear when we should be doing that? And who should be doing it when it needs to be done? And allied to that is the question of how we respond to a whole sequence of unwise decisions. Clearly, an unwise decision is not a reason to consider that somebody lacks mental capacity, but a whole sequence of unwise decisions over a period of time in the face of the kind of evidence that Stephen's decision making was facing could and indeed should cause capacity assessment to take place. So the third of the key lines of inquiry was interagency work, and here again some proactive information sharing between agencies, particularly between the district nurses, the GP, adult social care, and Stephen's landlord, in various combinations of things. And there was very close liaison with the family by the district nursing team, and particularly with Stephen's sister-in-law, who's the person who had reached out to him on behalf of the family, and who was supporting him on a maybe not a daily basis, but certainly a regular basis, and ensuring that he had money, that he had food, and in a sense looking out for him. And she was coming from a care background, so she knew what she was looking for, and what the concerns were. So there was close liaison, and indeed the family, brother and sister-in-law, have expressed a very strong appreciation of that liaison and how supportive they felt the district nursing service were during those last few weeks of Stephen's life. But on the more negative side, there was no coming together other than in small pockets of liaison, no multi-agency risk management processes, no meetings, and when a safeguarding referral was made by the district nurses, and that was not taken into Section 42 inquiry, the district nurses disagreed with that decision. But those differences of opinion were left unresolved. But the safeguarding board's escalation policy for resolving professional differences was not used. So there wasn't recourse had to trying to push for a resolution. There was no shared intervention plan until his health crisis, and there had been involvement between the Housing Association and Adult Social Care, between Adult Social Care and police, between the landlord and the Fire and Rescue Service. There had been attempts to develop an intervention plan, but that hadn't involved a kind of shared space until his health crisis. But even then, when Adult Social Care did work together with the district nurses, there was insufficient urgency in the light of the level of risk. So interagency working did leave some room for improvement there. And there are some ongoing questions about where do we take our concerns. Are our risk management pathways clear and known about? This was also something that came out from the thematic review, that practitioners are not always entirely clear what is the right pathway to take your risk concerns through. And then the second question is how do we judge and review what is urgent and what is a priority when situations are changing so very rapidly? Have we got the kind of speed? Are we nimble enough to be able to keep communicating between agencies, between practitioners, about such a rapidly changing situation? And then finally, the organisational context. What did we learn about what was going on in the agencies that might have impacted upon what happened at the front line with Stephen? I mean, all agencies have given assurance that their actions were consistent with legal and policy requirements, and there's no evidence to suggest that they were not. But there were clearly constraints at work within agencies, staffing capacity challenges in particular, which led to waiting times and also led to less consistency of personnel. GP surgery, in fact, has reflected that there's different GPs who might have seen Stephen had the same GP been involved, then that continuity of involvement and understanding might have given the GP surgery a kind of strong insight into the urgency of the situation. The concerns were expressed about whether current procedures for securing safeguarding action are fit for purpose in the context of risk to life. and also a challenge to the idea that decisions can be made on the basis of phone and text messages in which high risk factors can be missed. There was quite a strong push for written referrals so that all information is conveyed. There was a lot of debate and discussion at the learning event with the practitioners that we held about how we make sure that we are conveying accurately the level of our concern, and how are we ensuring that that level of concern is being received and understood by the person that we're talking to about it. And then finally, in the organisational context, there is some evidence, particularly from the learning event, of very extreme pressures on staff that made it very challenging to be working with the distress that being involved with Stephen was also causing. So staff were under extreme pressure. The words firefighting were used, the idea of being set up to fail by the pressure of work, and all of that leading potentially to burnout and despair. And this is not a Cumbria specific set of pressures. These are national pressures within safeguarding generally, but they were expressed very forcefully and very clearly at the learning event here. And it's important that we take note and address some of those pressures where we can. So those are the headline findings really from the 4 key lines of inquiry. I want to now just refer back to the thematic SAR with the 6 individuals that I mentioned earlier on in this talk. This slide pulls together the key findings from the thematic SAR. One of the tasks for me as a reviewer here with Stephen's review was to identify what did Stephen's situation tell us that we already knew, that's already been acted upon, and what did Stephen's situation tell us that's new, that perhaps didn't come out from the lives of these 6 individuals. So this slide just captures in a little bit more detail what we found from the thematic review. We found, in relation to whether needs were being met, that across the lives of those 6 individuals, we tended to focus on the most evident presenting need, that we tended not to dig below, peel the layers back to find out what was beneath the presenting need. We tried to, in a sense, solve problems, and the problems that we see in self-neglect are not easily solvable without really understanding what's causing them, without understanding what has been called the meaning of the mess. What is the meaning of the mess? That's the best possible foundation for being able to intervene in a positive and proactive way. But actually, in the lives of those 6 individuals, that sometimes wasn't happening, and we weren't really getting to the root of the problem. And there were multiple barriers to meeting need, and often those barriers came from the individuals themselves. People who self-neglect are very often very reluctant to engage. That's not because they know that they are doing okay. It's often because they are deeply ashamed. It's often because they are deeply traumatized, and that the self-neglect is a part of their pattern of response to trauma, and in some cases a trauma management response. So multiple barriers to meeting need, and of course we saw that reluctance from Stephen as well to engage. Risk in the thematic SAR, again, we saw this is very much resonates with what we found in Stephen's situation. Risk being either not recognised or assessed, or an absence of risk management planning, missed opportunities, and hazards remaining. So we're kind of stepping back from risk at a point where risk remains unmitigated sometimes. That was the case in those 6 individuals. I'm not sure that was quite the same in Stephen's case. Nobody was stepping back from trying to manage this situation towards the end of his life. Nobody was saying this is it's okay to leave it like this. So slightly different perspective from Stephen also, but I think what came out much more strongly from Stephen was the immediacy of risk and the need for fast action. And how do we secure that fast action? How do we persuade ourselves that that's what's necessary in the context of everything else that is weighing up for us all to do? Safeguarding. In the thematic review, we saw self-neglect not seen as safeguarding sometimes, and here again we saw that with Stephen, some agencies reflecting that they could have made safeguarding referrals but didn't. In the thematic review, there were assumptions that others would make the referral. That's not so much the case in Stephen's situation. There were issues with safeguarding triage in the thematic review, as indeed here, and in the thematic review, a failure of risk management action, and here in Stephen's case, of course, there were attempts to manage risk, but those attempts were ultimately not timely enough. Mental capacity, very much a common theme across the 6 cases that we looked at in the thematic review. The same kinds of findings, reliance on an assumption of capacity, no assessment, even where assessment would have been warranted. We also found in the thematic review, in one case where a capacity assessment had taken place and the person had been found to lack mental capacity, that wasn't followed by a best interests intervention, which it should have been. But of course, that wasn't the case in Stephen's situation because there was no formal capacity finding that he lacked capacity. Similar themes with working together, information sharing inconsistent, probably better in Stephen's case than in some of the lives of the 6 individuals, but similarly there, an absence of multi-agency meetings, similarly a kind of uncertainty about pathways and an absence of shared strategy and coordination. And then finally, similar kind of situations in the organisational context, challenges of staffing and time, challenges within agency culture and expectations in terms of what we think we are able to do in people's lives, and in the thematic review, situations where legal advice should and could well have been taken but was not taken. So there are some very strong similarities in some aspects of the thematic review findings between those findings and Stephen's case, and there are some new findings in Stephen's situation. So Stephen's SAR does, I think, leave us with some important questions. I've flagged up some of these as we've gone along, but I just want to gather them together here, that where we're working with people whose self-neglect places them at such extreme risk, so risk of death we're talking here, how do we manage their persistent reluctance? Are we clear how we respond to persistent and repeated unwise decisions, and when we should be assessing capacity under the Mental Capacity Act? Because it's important to know, of course, whether the individual's decisions and refusals are being made with mental capacity, because if they are, then that means we have to continue to build a relationship and work on trust and persuasion. If they're not, then we immediately have to engage with a duty to make decisions on their behalf in their best interests. In relation to interagency working, are we confident in our risk assessments? Do we worry enough, and do we worry enough soon enough? And are we, this is a really important one, are we equipped to identify extreme and urgent risk involving risk to life? But also, can we then communicate it accurately to other agencies? And can we ensure that we secure an effective risk management response? In relation to the organisational context, how can we adjust our workflow so that we can allow the more kind of persistent, professionally curious, relationship-based approaches that we know are going to be more effective with individuals who are self-neglectful? We did learn from the district nurses that they had adjusted their approach, their timing. They were spending longer with Stephen to try and talk and discuss with him. But that was so difficult within the context of the pressures of work. How can we ease some of those tensions and pressures? And how can we, within our organisational contexts, how can we better support practitioners with the personal experience of witnessing people living in such extreme self-neglect in the context of all the work pressures that people have? And so those questions really have led to some new recommendations for Cumbria Board arising from Stephen's case. So I think there are 2 slides here. So these are the final 2 slides. The recommendation to work on strengthening how we manage risk to life. This is about having a common language so that we know what we're talking about when we talk about extreme risk. What emerged at the learning event was that different agencies have different interpretations of the word urgent. And for some agencies, it might mean a matter of hours. For other agencies, it might mean 24 hours, or it might mean longer, might mean days. So we need a common cross-agency language. We need more kind of clarity for practitioners about how decision-making pathways are going to be followed. What decision-making pathway should be followed when there is risk to life? Where do we go with this? Can we create a kind of almost a fast track through to urgent action? And what are the indicators? If we can, what would be the indicators for that? How can we make sure that the right situations get taken down that pathway? And what would we expect to see happening if we did have an urgent risk to life pathway? So the second area is around strengthening communication and decision making about safeguarding referrals and other high risk circumstances. And there were calls for electronic referral arrangements, for some clear expectations on the detail and accuracy about levels of risk. And that possibly involves looking again at the newly updated board guidance on multidisciplinary team meetings and a relaunch of the escalation policy and monitoring its use going forward. Here was a situation where it could have been very useful and very important to use it, but it wasn't used. And then allied to that, we're looking for assurance on how agencies within their own case management systems flag cases of high risk, and how do we make sure that we communicate about those situations with other agencies in a continuous flow of information when situations are so volatile, but staff may be absent for a period of time? How do we make sure that information, that our IT systems help us to manage that information and convey it to others sufficiently quickly? And then the final 3, discussions with partners, for the board to have discussions with partners about how we can strengthen supervision and support to focus on these professional challenges of self-neglect and the personal impact of working with self-neglect, the impact of the persistent reluctance to engage by individuals in such high-risk situations. How can we make time and space for professional curiosity? We all know the phrase professional curiosity, but what are the things that prevent us sometimes from being able to express it? And what can we do to pick up really and to remedy that kind of level of frustration about the organisational context in which we're working, and to build some confidence in the potential for improvement? And, you know, the potential of a SAR, of a Safeguarding Adult Review, to make a difference. That's an important question for the board, I think, in terms of how it builds confidence in the SAR process and the learning process. We're looking from the review for a broader strategic partnership discussions about how the organisational pressures can be alleviated, and also consideration, because this is not just a Cumberland or a Cumbria based issue about the pressures on safeguarding and the pressures on staff working within safeguarding at the very sharpest end of risk. This is a national issue. Is there some, the report raised the question of whether the board might consider escalating that concern to match and meet up with similar concerns being expressed by other boards. So that is where I think I want to leave it. And I will stop my share. And Simon, hand back to you to take us forward, either if there are any questions that have come in through the chat, or if you then want to follow on. I think you were going to follow on anyway with some updates from the board's perspective about where things are up to in terms of actions in response to recommendations. But there may be questions that you want to address first.
Thank you, Suzy, and thanks for such a comprehensive overview of Stephen's experiences and the learning that identified, and it was really helpful to revisit and link with the thematic self-neglect SAR as well. So colleagues, I have posted the link to that in the chat, and I would encourage people just to read Suzy's executive summary from that SAR, which we published last year. What I'll do, if it's okay with colleagues, is I'll just take us through a couple of slides which will provide some update in respect of the board and the partnership response to Suzy's report. If that's okay, I'll just... Okay, is that coming through, Suzy?
Yes, it is.
Yeah, brilliant. So, as Suzy referenced in the slides that she's just presented, it was identified that there was, on occasions, a lack of MDT working, which again links back to not just the self-neglect SAR, but other SARs as well. We have recently developed and published some MDT guidance, and that's there, and it's intended to support practitioners to have the confidence and give them the autonomy to call an MDT when they feel that risks are escalating. We will be providing a formal launch of that guidance through our practitioner forum, and I will share following today's session a link, and I would encourage people to join that. The practitioner forum will be a very interactive session, and we will use a case study to explore how you can apply that guidance on a practical basis as well. It very much focuses in on kind of roles and responsibilities and recognising the importance of that MDT and that shared process, but also that shared risk as well, managing the risk. Other work that we've already started, so as Suzy referenced, locally in Cumbria we don't have any kind of multi-agency risk management model for where cases may not meet thresholds for safeguarding, or where there may be complex cases of self-neglect or high risk and escalating risk. We don't have a model for that locally in Cumbria. So currently we are doing some local mapping of different forums across Cumbria where safeguarding is considered. We wanted to do that to ensure that we're not duplicating anything in the system, and we're being as efficient as we can with the resources we've got. But helpfully we have also got some national modelling to draw on, which some of my other colleagues have developed, so we can see the examples of what's in place in other areas. And we will be taking that forward through our self-neglect task and finish group. So hopefully through the development of these two things, it will support us to develop that shared understanding and the shared language around risk across agencies, and that kind of shared decision making. So just moving on to safeguarding referrals, and I guess this links to risk as well. We have made some positive progress very recently through that self-neglect task and finish group, and we have developed what will be an electronic safeguarding referral form, and that will be purely for professionals to use, and they will be required to complete all of the information, which will then go straight into our adult social care colleagues. We have had some feedback from our partners involved in that task and finish group. So that's a really positive development. But I think what that will support is the accurate information gathering when people are making a point of referral, and it will inform the decision making process as well, where it will also support that shared understanding and responsibility of the safeguarding concern, including the risks, and provide the opportunity for a feedback loop to the referrer, because I am aware that that is something that has been identified as a concern. So I would anticipate there will be some kind of pilot phase for that. We'll probably be seeking to test that out, and then there'll be an implementation plan. But very much that will strengthen that referral process at the front door, encourage that shared ownership of safeguarding concerns, and seek to look for mitigations of risk as well. Because as Suzy covered earlier, it was very difficult when a safeguarding concern is raised on a Friday afternoon. The response that safeguarding concern will get will not make that person necessarily safe over the weekend. So that will really encourage that shared ownership as well. So in terms of training and guidance, we've been through that task and finish group. We have been developing and reviewing our self-neglect and hoarding framework tools, and we are imminently just about to sign off and publish a new suite of practice tools. They will be published on our website, but if you sign up to our news, and I will share that link, you will receive the information direct, and they are very much intended for practice and to support you as well. Hopefully as well, in terms of training, one of the recommendations from the thematic SAR was a recommendation to commission some shared self-neglect training on a multi-agency basis, and that will very much encourage that shared understanding as well of risk, as we referred to earlier, so that people across the partnership are working on the same page, so to speak. The reason we haven't commissioned that training before now is very much that we wanted to have that suite of practice tools available, so they could be referred to during that training, and the training could reference those and be based on those. But certainly that will again encourage a shared understanding across the system when practitioners are working with adults who experience self-neglect, and importantly where there are escalating risk. So just in terms of assurance, that one of the key functions of a Safeguarding Adults Board is for us to seek assurance from our operational partners, and certainly we will be seeking assurance from the partnership in relation to escalation processes. And whilst I have shared our escalation and resolution process for the board, and as Suzy has referenced, organisations do have their own internal escalation processes as well. So we would be encouraging practitioners to seek those out and to utilise those. I know lots of our provider trusts have internal safeguarding teams. They're there, they'll provide you with that professional advice, supervision and support as well, where risks are escalating. And we would very much encourage people to use their internal escalation routes prior to obviously then making reference to the partnership escalation process. We will also be encouraging our partners to identify opportunities through their organisational systems in relation to the recording and access of information. So we know that some of our partners have multiple records, electronic records, paper records, and not everybody can access those. And I think it's always helpful that people can access the information that they need when they need it. So we will be asking our partners to explore opportunities to improve their internal recording systems as well. And then, as Suzy alluded to earlier, that there have been some conversations at a strategic board level around the concerns that were raised at that practitioner learning event. And the board considered a supplementary report. We considered that again recently, just to explore some of the barriers and challenges that practitioners identified they experienced when working with Stephen. And as a partnership, you know, our leaders have recognised the importance of good quality supervision and support for practitioners, especially when you are working with cases like Stephen's, where risks are escalating and deterioration is very rapid. So we will be working, and we are in the process of developing an action plan to respond to that. As Suzy noted earlier, that does include some national escalation. So there is a national escalation protocol, and our Safeguarding Adults Board independent chair will be utilising that, and he will be reflecting back to the Department of Health and Social Care the learning that this review, and indeed other reviews, has identified in respect of those the challenges, the pressures, the workload, and the impact that has on staff and practitioners and your own well-being. So certainly that will be reflected back, you know, and one of the key conversations we've had at board is about staff welfare and ensuring that you have access to the resource and support you need. However, I do recognise that change won't happen overnight, but I would encourage you to seek out safeguarding supervision, seek out advice and support when you're working with cases of extreme self-neglect, and you know, you are facing some of these challenges. We do have a range of resources on our website, and as I said earlier, there will be some more resources and new refreshed self-neglect resources uploaded, but certainly I would encourage you to reach out internally as well to your through your management structures, so that you get the support you need when working with individuals like Stephen. So just finally, I think there are some opportunities, and I would encourage you to get involved. Obviously, we have shared ahead of today the SAR report. I've also shared the self-neglect report there as well, and I will do again after today's meeting. I would signpost you to our website. There's lots of resources, guidance and recordings of different learning sessions that you can utilise in team meetings or indeed for CPD purposes. I would encourage you to sign up to our news and briefings. That's the route in which you will, sorry, this just popped up my screen. That's the route in which you will receive notification about the new guidance and tools and the learning opportunities. I will share a link if colleagues are interested, and I would encourage people to join us at our next practitioner forum, where we will explore that MDT guidance and how you can use that in practice. And it will be a very interactive session, very different to today. So I would encourage people to join us. And also, as I referenced earlier, during the autumn, we will be delivering 2 tiers of multi-agency self-neglect training as well. But finally, as you will be aware, you also have access to your own individual organisational training and guidance, so would encourage you to access that as well.